Thank you very much for the kind invitation to come and speak with you today. Before I start, one thing I always learned was know your audience. So who in the room is a healthcare professional? Just raise your hand. That's actually pretty good. Okay, and how many people are patients or patient advocates or, laymen? Okay, good. Okay. My job is to spend the next hour roughly talking to you about the approaches for high-risk localized prostate cancer. I'm going to talk to you a little bit about the present and the past, and a little bit about the future at the end, and some interesting research that's ongoing at our institution and soon to be rolled out in a phase 3 trial that I think is going to profoundly change our management of patients with high-risk disease. So I always like to start with a little case series to make it a little personal. This is a real patient, a 62-year-old male who presented with a PSA of 8.3 and a rectal exam that was a little abnormal. No family history of prostate cancer. His PSA had been checked six years previously and found to be about 1.2. I think one of the things that was highlighted very nicely by Dr. Hu was this change in screening may have impacted particularly the younger patients in terms of whether they go ahead and they get screened, and I think that's a real loss because patients like this pop into our clinics all the time now. He had a needle biopsy which showed Gleason 9 cancer in 4 out of 12. His imaging was negative. We got an MRI which showed possible extracapsular disease, meaning the disease is growing outside the prostate, and he was a pretty healthy guy. So this is the data that existed about a decade ago. In red, you can see the gradual decrease in high-risk disease, the sort of stable intermediate risk disease, and the increase in low-risk disease. This is captured data, a rather large study ongoing from UCSF, University of California, San Francisco, out in California. And I think this is the image that everybody had in their heads, was we're having more and more low-risk disease, doesn't need to be treated, less and less high-risk disease that is of low risk to the patient. So this is data that one of our talented medical students put together, and which he looked at the National Cancer Database. This compromises almost 70% of the patients diagnosed with prostate cancer in the United States. And what you can see is there's been now a reversal of this trend, an increase in the percentage of patients who present with high-risk disease, relatively stable for intermediate, and a fairly dramatic decrease in the percentage of patients with low-risk disease. Now, these are percentages, not absolute numbers, so this could be viewed as a very good thing, that we have less low-risk disease. That's good. We don't need to diagnose that. But the increase in high-risk disease is worrisome. And so I'm going to talk to you a little bit about what, at least in my opinion, is the best management for these patients. And obviously we need to think about androgen deprivation therapy, radiation therapy, and surgery. And I think increasingly we need to be thinking about multimodality therapy. That means the patient won't need one therapy to treat the high-risk disease. They need surgery, androgen deprivation, and radiation in many cases to cure them. So what about no treatment? I mean, that is an option. That was essentially part of what Dr. Hu was talking about. This is a rather nice study by Peter Albertson's group, looking at roughly 14,000 men diagnosed with localized disease between 1992 and 2002. These are older men because they are Medicare, over the age of 65. The mean age was 78. So these are exactly the kind of men that you think would be reasonable to follow their cancer. And they analyzed them for both cumulative mortality, meaning whether they were alive or dead, and then specifically whether they were alive or dead from prostate cancer. So the darker line is the risk of dying of prostate cancer, the lighter color is the risk of dying of something else. And I think what's very striking here is there's a lot of patients that are dying of prostate cancer if you don't do anything, and these patients that have high-grade prostate cancer, even though they're older. I mean, the average age is 78. So I think we need to bear that in mind, that maybe no treatment in patients with high-risk disease is a bad idea. This is a study that was done by one of my fellows, also looking at SEER data, almost 300,000 patients, so it's not limited to a Medicare patient population. This is all ages. And drilled down into the patients that had T3 disease, that means the cancer is growing outside the prostate, and had no curative therapy, which is a relative minority. I mean, if you look at this, it's going to be roughly 1% of the entire population. And so the same idea that the dark black is the risk of dying of prostate cancer, the lighter color is the risk of dying of something else. And what you can see is there's an awful lot of black here, both in the low and moderate grade, but particularly in the high grade. I mean, that's very striking. Even if you're over 80, you have almost a 50% chance of dying of prostate cancer if you have T3 disease, Gleason 8, 9, or 10, and you're not treated. So not treating patients is probably not a good option. I find a lot of people like to use primary androgen deprivation. That means just removing the androgen, not treating the localized disease, and I can give you a strong argument why that's not a good idea. So again, this is also the study from Peter Albertson's group, roughly 60,000 patients who were treated with either androgen deprivation alone, so no radiation, no surgery, just hormone ablation, versus no treatment, okay? And this was between 1992 and 2009. They had a median follow-up of almost 10 years. So Kaplan-Meier curves are something that's very familiar to the medical folk in the room, but maybe not the laymen. But essentially what you do is you draw a line and over time, and it goes ahead and tells you whether you're going to be, an event's going to happen. And this is a percentage, okay? So this is the moderately differentiated prostate cancer, and believe it or not, these are two lines that exactly overlap one another. Okay, meaning there is absolutely no benefit to androgen deprivation therapy versus observation in this patient population. And if you look in the poorly differentiated prostate cancers, you find about 20% of the patients have died, and it makes no difference whether they got androgen deprivation or not. And if you look at overall survival, you see exactly the same thing. In other words, this is not a comparison of this line versus this line. There are two lines here, and they overlap so perfectly that you can barely tell there are two lines. So basically, androgen deprivation as monotherapy, meaning the sole therapy, really should not be used in this patient population. The other reason for it is because radiation and hormones together have clearly been shown to be better than either one of them alone. So the granddaddy of all these studies was published, actually the first study was published back around 2002, 2003, but the update was done in 2010. This is roughly 415 men who have high-grade disease or high-stage disease, and they were randomized to 3 years of hormone therapy with radiation or radiation alone. And they looked at things that were important, like whether the patient was alive or dead, whether they died of prostate cancer, which I think are really the issues that most patients care about the most, as well as clinicians. So unlike the other study where the two lines overlap perfectly, here you can see there's definitely a nice spread between the two of them, which is somewhere between 20 to 30%, depending on what your time frame is. This is years across the bottom. Radiation alone is the top line. Radiation and hormone therapy is the bottom, and you can see you're much less likely to die of prostate cancer if you receive radiation and hormones versus radiation alone. This is overall survival. I wish they'd put the curves in the same direction, but they didn't. So the top one is better than the bottom one. The top one is radiation and hormones, meaning they are less likely to die, period, if they receive both, versus the bottom one, which shows that if you had radiation therapy alone, you're much more likely to die, period. I mean, unfortunately, the curves do come together. That's at about 16 years. I think that basically tells us that, you know, for better or for worse, people don't live forever. Now, there have been multiple other trials that have sort of looked at this over the years. This is a sampling of them. And the debate that radiation oncologists get into is how long you should treat someone with hormone therapy. So they don't get into a debate about whether they should use it or not in high-risk patients. It's whether or not, how long the therapy should be. So all patients with high-risk disease, in my opinion, that get radiation therapy, I won't say all, vast majority should get hormone therapy as well as the radiation. So the question I always asked when I first saw these studies is, how do we know the radiation therapy is doing anything? Maybe it's all the hormones, right? So this is a nice study where they took 1,200 patients who had high-risk disease, so T3, T4, meaning growing outside of the prostate, or patients with a very high PSA, 40, or Gleason 8, 9, and 10, and a PSA over 20. So these are patients with very aggressive prostate cancer. And they randomized them to just androgen deprivation versus androgen deprivation plus radiation. So you remove the hormones for the rest of the patient's life, and you treat them with radiation, or you just remove the hormones. And at 8 years, they showed that the likelihood of dying of prostate cancer was roughly half. That's what 0.5 would be half. This is at 0.46, so it's better. It's better by over 50%. And the overall mortality is 0.7. Again, that's showing a substantial benefit in whether the patient is going to be alive or dead. So this is the curves. This is androgen deprivation therapy alone. This is androgen deprivation plus radiation. You can see the patients that got androgen deprivation alone did not live as long in terms of prostate cancer as the patients who had radiation. And impressively, at 12 years, the curves are still getting farther apart, meaning as you get farther and farther down a person's life, the more and more likely they are to benefit from the dual treatment. And when you look at overall survival, you see exactly the same thing. Patients who received radiation and androgen deprivation did better than patients who received received androgen deprivation therapy alone. So the latest thing for patients with high-risk disease is if radiation and hormones are better than either one alone, what about giving even more radiation? So instead of just giving external beam radiation, you give brachytherapy, that's little radioactive seeds that go into the prostate, and external beam radiation therapy and hormones. Is that better? Is more better, or is more just more? So they took, in a randomized fashion, roughly 400 patients. Half got androgen deprivation for 12 months, plus radiation, external beam radiation, plus a radiation therapy boost, because that's not enough radiation, versus taking about the same number of patients, same primary treatment, but instead of giving the boost, they gave brachytherapy, the little radioactive seeds. And a median follow-up of 6.5 years, roughly 70% of these patients had high-risk disease. So it was intermediate and high risk. And this is what it actually looks like. They looked at biochemical failure. The top group are the patients that received the brachytherapy in addition to the external beam, and you can see there's clearly a benefit there. Okay? If you look at the intermediate risk disease, again, those are the patients who received the combination with brachytherapy. They did much better than the patients who did not. And if you look at biochemical failure in the high-risk patient population, you see exactly the same thing. The patients who received more therapy did better, less likely to have a biochemical failure. No benefit yet for overall survival, but again, they haven't followed the patients long enough, and it'll be interesting to see what happens as they continue to follow these patients. Now, there's a cost, unfortunately. We always talk about the success, the cure, but there's a cost, and more comes with more cost. And I don't mean money, I mean toxicity. So the early primary toxicity was primarily due to the androgen deprivation, hot flashes, loss of libido, fatigue, etc. G1 plus toxicity, that really means any toxicity, any side effect that the patient had, was more in the combination arm at every time point. The G3 plus toxicity, that's serious toxicity. That's not a little, I felt a little tired. That's having something bad happen. Okay, terrible infection. In our cases, things like strictures, unable to urinate. That was also higher in the combination at every time point. And just to put a number behind it, if you look at G2 plus toxicity, which is not minor, it includes most of the toxicity except for I won't say silly stuff, but I mean, fatigue is not a huge price to pay. The GI toxicity was 5% in both arms, so no difference. But for the GU toxicity, which includes things like strictures, fistulas, inability to urinate, it was roughly twice as much in the XRT and brachytherapy arm than the radiation therapy alone. I mean, 20% is fairly substantial. And we look at the long-term GU toxicity. In the radiation therapy alone arm, it was about 2%, which I think reflects what we see in our clinic. But if in the combination arm, it was almost 9%. So I think we'll treat more patients successfully by using this combination. But I think there's going to be a cost. A lot of patients are going to come in with urologic problems, and that we as urologists will have to manage, which I think is a problem. So in conclusion, Gleason 8 through 10 cancer, T3 to T4, they need treatment. I think that's very self-evident, but when you see that 77, 78-year-old guy, 80-year-old guy walk into your office and you think, oh my God, maybe I shouldn't do anything. No, he needs something, okay? I think that he needs, because observation is associated with a very high mortality rate in this patient population. Radiation and androgen deprivation is better than androgen deprivation or radiation therapy alone. And I think increasingly, at least at our institution, really the combination of external beam, brachy, and androgen deprivation therapy for this patient population is taking over for patients just getting external beam and androgen deprivation, though I am concerned that 10, 15 years from now, there'll be a huge price to pay for those patients. So I'm a surgeon, so obviously I want to talk about surgery, so I'm going to spend the rest of my time talking about that. At surgery, the first question I think you have to ask is surgery curative? Okay? And I think the answer to that is an unambiguous yes. Okay? Why do I say that? Well, this is a rather nice study that was published over a decade ago from Memorial Sloan Kettering, where they looked at about 4,700 patients treated between 1985 and 2004, and they identified 8 different ways to classify someone as high-risk disease. So, and then they looked at the progression rate, where the patient was likely to have a biochemical failure. So hopefully this projects well to the back of the room, but there are multiple different ways of defining high-risk disease, ranging from just the high Gleason score to high stage to high PSA, and then various different ways that we as urologists slice and dice this. And I think the bottom line is when you look at these, really patients that have high-risk disease, roughly at 10 years, roughly 50% of these patients were cured with surgery alone. We decided to look at it and see whether they were alive or dead, which again, I think biochemical recurrence is important, particularly in patients that have high-risk disease. If somebody has Gleason 8, 9, or 10 and you operate on them, or you give them radiation, they have a recurrence, that's not good. We all know that. But still, what we ultimately care about is whether our monotherapy, whether our intervention actually has an impact on patients' lives. So we looked at roughly 6,500 patients, operated on slightly later than the Memorial series. We had follow-up, which was slightly shorter, and we identified 6 different ways to classify high-risk disease. And we looked at prostate cancer mortality and overall survival, because again, that's what patients and we care about ultimately. And a very similar result. So at about 75% of the patients at 10 years were still alive, hadn't died of prostate cancer. And it very similar for overall survival. There was obviously some patients who died of other causes, but the majority of the patients were still alive after being treated with surgery roughly 10 years afterwards. I think the best data actually support the intervention in patients that have high-risk disease is a randomized trial that was done in Sweden almost 2 decades ago, most recently updated in 2014. They took roughly 700 patients who were randomized to either radiation versus observation. Importantly, for why I think this reflects high-risk disease, is these patients predominantly had clinical disease. These were not patients that were picked up by PSA screening. Only about 10% of them were identified in that way. All had localized disease, but all grades, however, and they had roughly 13 years of follow-up, and they found basically that radical prostatectomy was superior no matter how you look, whatever parameter you looked at. Disease-specific survival, whether they were alive or dead from prostate cancer, metastasis-free survival, whether the cancer had spread, and lastly, overall survival. Now, why do I think this reflects high-risk disease? Because, look, only about 12% of those patients were picked up by PSA screening. Roughly a half of them had T3 disease at the time of surgery. A third of them had positive margins. A third of them had Gleason 4+3 or greater. PSA is greater than 10 because they could measure the PSA afterwards because they had blood in order to do that. But 50%, and PSA is over 20 in 20% of the patients. So while this trial did not focus on high-risk disease, I think that many, in fact probably the majority of the patients had high-risk disease or fairly advanced intermediate-risk disease. So this is the actual curves. Hopefully, again, it projects. These are patients who received radical prostatectomy. These are the patients who received watchful waiting. Again, this was not an active surveillance trial. The control arm, the patients essentially were treated with benign neglect, in my opinion. So the green is the likelihood of dying of prostate cancer, and you can see that it's better for patients that received surgery. What's less evident is the patients, these are other causes, patients who develop metastatic disease and were treated with androgen deprivation, and that's actually also less in patients who received surgery. And any man who's been put on androgen deprivation knows that it's not fun, and to put somebody on lifelong androgen deprivation because that could have been avoided by treating the localized disease is actually a loss. Overall, prostate cancer mortality was roughly half in the patients that were treated with surgery. This was an absolute reduction of 11%, and that the number needed to treat was 8, which, so you treat 8 patients and you save 1 life, which is a fairly good number, comparable with other treatments for cancer. The other randomized trial I don't think really reflects this patient population. It's the PIVOT trial. This is a study done in the United States, which had a lot of flaws associated with it. which I don't want to go into, but roughly 21% of these patients had high-risk disease. And when this is the latest iteration of the trial published last year, you know, the overall survival, the p-value, we like the p-value to be less than 0.05. You can see that the overall survival, the cancer-specific survival, and in particular the metastatic-free survival actually favored the intervention. So these two came close but didn't quite make it. This one actually favored the intervention. Again, as I advocated earlier, getting metastatic disease is no fun. I've never seen them look at that 21% that had specifically in that group, that subset analysis, except at the AUA when he initially presented the data. They actually showed that the hazard ratio for patients who had high-risk disease on the basis of PSA, Gleason score, and stage, again, roughly halved the risk of dying of prostate cancer. And, you know, in and of itself, I would not hold this up as proof that the intervention helps if it didn't so nicely match the results from the Swedish trial. So is it better? Is it better than radiation? The short and the long answer is I don't know. Probably the best study to look at this is, again, a study that was presented earlier by Dr. Hu, looking at it's called the PROTECT trial. It's a randomized trial of active management. I want to emphasize that again. It's not active surveillance, it's active management. While we're not really talking about that aspect of it in this talk, the problem with active management is they just followed the PSA. They did not have MRIs, they didn't have repeat biopsies, and as a result, I cringe when people sometimes cite this as a study that shows that active surveillance is not as good as intervention because the metastatic rate was slightly higher in the active management group, and I don't think it shows that at all. This was fairly modern radiation therapy, and these were PSA-detected cancers. So these are the kind of patients that we're seeing all the time, okay? This is, you know, I've shown all these curves where the curves come down like this. That's not a top of a box. That's the curves for the three. And it doesn't take a genius to look at that and say, look, prostate cancer survival is absolutely no different in all three groups. And 99% 10-year disease-specific survival in all three arms. But only about 25% of these patients, only about 2% of these patients had high-risk disease. So I think this study actually does not provide us any information on how to manage high-risk prostate cancer. And I would actually argue it probably doesn't give us a lot of information, or at least is not as much information as I would like in terms of the management of Gleason 6 and Gleason 7, because it's not really active surveillance, it's active management. And 10 years is not really enough to demonstrate an advantage for a treatment for prostate cancer. The physicians in the room know that we've probably fed people corn who had Gleason 6 cancer and told them it was a treatment. They'd still all probably be with us at 10 years. It's a rare patient with Gleason 6 cancer that progresses at 10 years, even with no management strategy. That's why active surveillance is so great. So surgery, this is the best. You know, if we don't have randomized data, we're left with case series, okay? This is a rather nice meta-analysis where they went ahead and took all of these different studies, including mine, that looked at patients who had surgery and radiation, and then put all the data together to get closer to truth. I put truth in heavy quotations because it depends on statistics, and any of us who work in this field know that statistics are an imperfect tool in order to identify differences. It's better than anything else we have, but it's imperfect. So this is a lot of patients. I mean, 120,000 patients. In this curve, if you're on this side, that means that radiation is better. If you're on this side, that means radiation is better. And what you can see is pretty much all the studies show that overall survival is better if you have surgery, and that's the amalgamation of all of them. And that has a hazard ratio of I think it says 1.63. That's an improvement of more than 50%. If we look at patients that have low risk, intermediate, and high risk disease, okay, and we're obviously interested in the high risk the most, that's the biggest benefit. In fact, for want of a better phrase, there's a dose response here. It's not really a dose response. I'll sit down at the table and people will be critical of me for using that phrase. But the idea that the patients that have more aggressive disease benefit the most is in keeping with the treatment actually providing the most benefit. I know that sounds sort of circular, but we expect a lot of these low-risk patients don't need any treatment. So it's going to be hard to demonstrate a benefit. Whereas the patients with high-risk disease, they need treatment. So we're much more likely to see a benefit if the treatment actually works. When we look at prostate cancer survival, we see something extremely similar. All the curves, all the studies basically show a benefit except for one. And when we amalgamate all the studies together, we can see that there's an improvement in survival of about 2 for patients who get surgery. Again, I think this is in keeping with an actual effect because, again, we would expect that the cancer-specific survival should be better than the overall survival because in both arms, people die of other causes. Again, when we break it down into low, intermediate, and high-risk disease, you can clearly see that the benefit increases as you have higher risk disease. So low risk, it's 1.7, intermediate risk, 1.8, and high risk, it's 1.83. Again, consistent with the idea that the patients who need a treatment are getting an effective treatment. So why surgery? Why is surgery better? Patients with, I'd love to stand up here and say, yeah, surgery is better. I think it is. But I think a lot of it is that patients with high-risk disease often, but not always, need additional treatment. And I think both the often and the not always are important because when we go ahead and we have a patient that's treated with surgery, we have optimal staging, optimal adjuvant treatment, and optimal salvage treatment. And our radiation oncologic colleagues have trouble providing that simply because they don't have pathology. So we give the right patient the right treatment at the right time. So what do I mean by optimized staging? So Jonathan Epstein did a very nice study where he took 1,400 patients where they had needle cores and they also had radical prostatectomy specimens, and they compared the radical prostatectomy grading to the needle core grading. And so the important part is right here. These are patients that had lower intermediate risk disease on the, I think I might have this backwards actually. Basically, these patients had a high-risk disease, they had high-risk disease on the biopsy core, but eventually were found to have lower-risk disease when we actually had the radical prostatectomy. So they would have been over-treated by getting radiation and androgen deprivation. They would have been labeled as having high-risk disease when they don't actually have it. Conversely, there are patients who have high-risk disease on the needle core and then are found to have low-risk disease when they actually have, low-risk disease on the needle core, and when they actually have the surgery, they're found to have high-risk disease. And that does have an impact on survival. So this is a nice study using a VA database called the SEARCH database, roughly 4,000 patients undergoing radical prostatectomy, and these were patients that were thought to have high-risk disease on the basis of the needle biopsy. And these patients, if they had radiation, would have gotten 2, 3 years of androgen deprivation in addition to the radiation, but they were not found to have high-risk disease at the time of surgery. And when you look at it, these are the patients that did not prove to have high-risk disease. These are the patients who had high-risk disease. And you can clearly see the patients that were falsely identified as having bad cancer, they didn't really have bad cancer. They had very curable cancer. And so I think this argues that patients can be identified and the treatment can be tailored for the patient's actual risk as opposed to their appearance of risk at the time of biopsy. So you can tailor the additional therapy after the surgery, which I think is incredibly important. So this is a randomized trial that was done many years ago looking at patients who had high-risk disease at the time of radical prostatectomy, and they were randomized to receive adjuvant radiation therapy, meaning they got radiation therapy after the surgery just on the off chance that there was some cancer left behind. And they had good endpoints, whether or not there was cancer that had spread, and also whether or not they had survived, whether the PSA came back, or whether they recurred. And these are, again, those Kaplan-Meier curves. The top curve is the patients who received adjuvant radiation, and the bottom curve are the patients who did not receive adjuvant radiation. And this is a statistically significant difference in the likelihood of the cancer spreading. So if the patient had some cancer left behind, treated with radiation, they're more likely not to have the cancer spread because of effective local therapy by the combination of surgery followed by radiation than surgery alone. Looked at overall survival, they find exactly the same thing, that there was an improvement in overall survival in the patients who received the adjuvant radiation versus the patients that were just observed. Now, there have been other studies subsequently that have looked at this that have not shown as much of a benefit. And I think by delving into that data, we can identify the patients who might actually benefit from adjuvant radiation. So this is a very similar study that was done a few years later, looking at roughly 1,000 patients, so a larger patient population, but essentially exactly the same trial. Their endpoint, though, is a biochemical-free survival, not a metastasis-free or an overall survival. And I think that's important as we go through the data. So this is the benefit. This is the important figure, which shows a tremendous improvement for adjuvant radiation versus control. So patients who receive radiation did incredibly, I mean, that's a fairly dramatic difference, okay? That's a roughly 30% improvement in biochemical control. And it's durable. I mean, that's out 16 years. But when you look at clinical progression or death, yeah, it favors the adjuvant radiation, but not so dramatically, okay? And that's not statistically significant. That's not their primary endpoint, but still, it's interesting. And then when you look at overall survival, the control arm, this is not significant, meaning there's no proof that one's better than the other, but if you had to bet which one was better, the control arm would be better, the people who did not receive radiation, which is interesting. When you look, this is a forest plot, so everybody on this side benefits from radiation, everybody on this side does not benefit from radiation. And they broke it down looking at PSA, what the margins were, what the stage was, what the risk factor was. Bottom line is, no matter how you looked at it, patients did better from a biochemical standpoint, meaning a likelihood of the PSA coming back if they got the radiation. I want to just draw your attention here at the bottom, because I'm going to come back to it. Less than 65, I think that says 65 to 70 and greater than 70. And you can see this, it's a little intriguing here that this is getting a little closer to this magic line of 1 that predicts who's going to actually, you know, which side of the curve you should, which side of the graph you should be on. You look at clinical failure, I think it's interesting. Everything moves a little bit to the left. And now take a look at this older patient. Now it actually, again, this is just what we call hypothesis generating. Gives us a clue that maybe there's something going on. This patient actually didn't do as well. The clinical failure rate was higher in the patients who got radiation. And then when you look at overall survival, now the curves are sort of trending towards the side of not getting additional therapy. There have actually been 3 trials that have looked at this. This is the first trial I showed you. This is the second trial I showed you. And then this is a third trial, a German trial, with much shorter follow-up, only 5 years. And when you look at biochemical-free survival, all of them demonstrate a benefit, all of them. When you look at clinical progression, yeah, that one shows a benefit, but these two, I mean, this one doesn't, I mean, 98 versus 97%, my God, everybody did very well, okay? Local failure, again, appears to benefit the treatment arms. That makes sense. If you have cancer that's left behind, should benefit. Toxicity, reasonably high in the first trial. The other 2 trials don't really have as much toxicity, but they didn't really measure GU toxicity. They mostly just measured systemic toxicity to the radiation. And only one showed a benefit to overall survival. The big thing that happened between this study and these 2 studies is PSA. So what happened is, in this study, PSA wasn't really being widely used. The idea was you either give the patient treatment now or you wait until they develop metastatic disease. Now, PSA did come into play as the trial progressed, but at least it wasn't being widely used. Whereas in these 2 studies, the patients were getting PSAs. And I think what happened in a lot of patients is they had a PSA, the patients that were put in the non-treatment arm, the PSA was followed, and if the PSA ever went up, a lot of them got radiation therapy at that point in time. And there are randomized trials that are looking at that, but they have not been published to date. And the longer we wait for the publication to come out, the more I believe that there's no difference between the 2. Because I've been giving talks like this for about 10 years, and I haven't seen any results from those trials. Salvage radiation, I think, is used much more frequently. And the key thing with salvage radiation therapy is to give the salvage radiation when the PSA is low. So this is a nice study by Andrew Stevenson at the Cleveland Clinic. He looked at roughly 2,400 patients, 10 different academic centers that underwent salvage radiation at a variety of PSA levels. So this is a PSA level, boy, I'm having trouble reading on my own screen. Hopefully you can read it up there. I think that's 0.02 to 0.2, and gradually increases until you have greater than 2, PSA of greater than 2. And you can see the likelihood of biochemical recurrence is much less if you give the patient the radiation with a low PSA than you wait until the PSA gets higher. And again, I'm just harping on this over and over again. This is metastasis-free survival, a much harder endpoint, a much more, I mean, you know, at the end of the day, nobody cares that a number is wrong. What you care about is the cancer spread, is the cancer a threat to somebody's life? And this shows much better results if you give the radiation when the PSA is between 0.02 and 0.2 than if you wait. So one of my concerns whenever I send a patient back to the internist is, we all deal with these electronic medical records all the time. And it just spits out what's normal, what's not normal. I do it. I send off a CBC. That's where we look at the blood count. If nothing comes up as a red flag, I don't worry about it. I have seen patients where they're being followed by their internist who's totally overworked, is having to manage hypertension, sexual dysfunction, social issues. My God, it's hard to be an internist in 2018. And the PSA says it's normal at 1, so he doesn't even think about it. And the patient turns up in my clinic when the PSA is 4. They come back. And so I think it's an issue. But as a urologist, we need, and as a patient, you should pay particular attention to your PSA after treatment. Hormone therapy, I think, is useful in this patient population. This is a study now published over 10 years ago, rather small study, only 98 men, where they gave patients who had node-positive disease, they gave them hormone therapy, not radiation, hormone therapy, and they found that there was a benefit both in terms of metastasis-free, cancer-specific, and overall survival. So again, you see the patients who received hormones right away did better in terms of whether they were alive or dead than compared to the patients who were observed. It's unclear if androgen deprivation at the time of PSA failure would not be equally effective, and I think that's what a lot of us have sort of turned to, and I'm going to go into the data that would support that in a second. It's unclear if intermittent therapy would be as effective. That means you stop and you start the hormone therapy, which has clearly been shown to improve patients' quality of life. Or I shouldn't say that, have not been as much of a detriment to the patient's quality of life. And I think it's unclear if the data on node-positive patients could be extrapolated to other patient populations. It's clear, though, so this is a SEER study which looked at roughly 700 men with node-positive disease at the time of radical prostatectomy. This is not a randomized trial. This is just how the patients did. They found about 200 of the patients who received adjuvant RT. Adjuvant ADT, I apologize about that. Roughly a third of the patients had died. 10% died of prostate cancer, and they found no improvement in overall survival or prostate cancer-specific mortality. Again, I apologize about that. It should say adjuvant ADT. So if you look at this, this is the likelihood of being alive or dead, and really no difference between whether the patient received hormone therapy or the patient was observed and was given hormone therapy at a later date. And when you look at the likelihood of dying of prostate cancer, you see something that's very similar. So for that reason, I think most of us hold back on giving the hormone therapy until the PSA starts to rise. Radiation is increasingly playing a role in combination with androgen deprivation in patients who have PSA failure. So these are two different studies that looked at a reasonably high number of patients, about 700, who had PSA failures after radical prostatectomy. And the patients were treated with radiation versus radiation plus androgen deprivation. This study from Europe showed an improvement in progression-free survival. This study from the United States showed an improvement in overall survival, despite the fact that they gave bicalutamide, which is not great androgen deprivation therapy. So when you look at this, you say, okay, good androgen deprivation improves progression, bad androgen deprivation improves survival. Likelihood, as these patients are followed out longer, we'll start to see a benefit from the combination therapy. So these are the Kaplan-Meier curves. Death from prostate cancer. This is the patients who receive placebo, much more likely to die than the patients who receive bicalutamide in combination with radiation. And when you look at overall survival, you see the same benefit. Bicalutamide plus radiation was better than radiation therapy alone, and that's statistically significant. So that's why increasingly we're giving patients 6 months of androgen deprivation in combination with the radiation for patients who fail primary therapy. So adjuvant versus salvage radiation therapy, good data that both works well. Adjuvant clearly overtreats patients. There's absolutely no question about it, because you know patients who fail anyway, well, they were overtreated, right? Patients who never failed, well, they were overtreated as well. Salvage clearly undertreats some patients. I am sure that there's some patient who comes in that we decide we're not going to treat right away, and they go ahead and they fail, and they wouldn't have failed if we treated them right away. I would argue that's an incredibly small number if you go ahead and your trigger is a very low PSA. I tailor the post-op radiation. Tailoring the post-op radiation is central to cure. And if you're going to give radiation, I think in this day and age, you need to give it with androgen deprivation. As I said, at least at our institution, it's 6 months. So last piece of my talk, I'm going to talk about in the last 20 minutes, surgery plus for high-risk disease, is it good enough? And I'd say not always. So this is very similar data that I showed you before. This one's from Scott Egner, basically looking at a variety of different patients with a variety of different stages. And the black is whether or not they were alive or dead from prostate cancer, and the gray is whether they were alive or dead, period. And what you can see is the risk of the disease increases. This is low-risk disease. This is high-risk disease. The black gets increasingly thick. In fact, there's approximately 1 in 3 risk of death from prostate cancer at 15 to 20 years if you're treated aggressively with surgery. And I don't think any urologist in the room thinks that's good enough. So what's the future? And I think the future is systemic therapy. So this is not going to be a talk on systemic therapy, but I think everybody in the room needs to understand that increasingly we're no longer just using androgen deprivation to treat patients with metastatic disease or rising rising PSA patients. We now have docetaxel, which is a chemotherapeutic agent that has created patients who have metastatic castrate-resistant docetaxel-resistant tumors. And now we have things like abiraterone, enzalutamide, carbazitaxel, radium-223, CYP-T. All of these treatments have been shown to make patients live longer. And the question is, if we give these agents earlier, when patients have locally advanced disease, can we go ahead and improve our cure rate? These are the studies. I'm not going to go into them, but basically all of them show a benefit to the various treatments I just outlined. I think the key thing that everybody here needs to realize is this improvement ranges from 4.8 months to 1.8 months. That is not a huge improvement in life expectancy. I think there's not a patient in this room or a patient anywhere who wants to hear, yeah, we'll give you this drug, it'll make you live longer, but only 2 months. Earlier treatment has now been shown to extend that 2-month life expectancy benefit to somewhere between 12 and 24 months. There are at least 4 different studies, 2 looking at docetaxel, 2 looking at abiraterone, which abiraterone is a very strong hormonal agent, that have shown that patients will live longer and substantially longer. So this is just one study I pulled up. This is ADT plus docetaxel. This was done by one of my partners, Chris Sweeney, a very talented medical oncologist at the Farber. Where the patients got androgen deprivation plus docetaxel in patients who had metastatic cancer. So this is not treatment of localized disease. This is treatment of metastatic disease. Very high burden disease. And they followed the patients and found that they improved the time until the patient developed more aggressive metastatic disease, castrate-resistant disease, by about 8 months, and the time until death improved by about over a year. This is the Kaplan-Meier curve, basically showing that the combination of therapy with docetaxel, chemotherapy plus androgen deprivation in patients who have metastatic cancer was better than receiving androgen deprivation alone. And there's a second study that's shown exactly the same thing. Same thing has been shown with abiraterone. Again, this is a very strong hormonal agent that blocks the production of testosterone. Roughly 1,200 men receiving androgen deprivation plus abiraterone, very high-risk features. Again, these are patients with metastatic cancer, okay? And we saw an improvement in progression from 14 to 33 months, that's more than a year, and an improvement in overall survival, which is hard to quantify because they haven't even reached, in the arm that received the hormone therapy, the aggressive hormone therapy, they haven't even reached the median survival. So again, this is the trial, basically showing a substantial improvement to the patients who received abiraterone with hormone therapy versus placebo alone. And again, there's a second trial which showed exactly the same thing. So from the idea here is we have localized, the disease progresses from localized disease to metastatic disease to end-stage disease. And if we treat patients with end-stage disease, well, we improve their life expectancy by 2 to 4 months, which I don't think anybody thinks is a win. Metastatic disease, that's what I just showed you with the abiraterone and the docetaxel data. So the cancer is spread, but it's not reached that end stage. We improve survival by 12 to 24 months, which I think is pretty impressive, actually. For my training, when there was no treatment like this that worked at all, I think that's a substantial improvement. And our idea is if we go ahead and we give them perioperative treatment, we'll cure some of these patients. So, and this has been shown in other diseases. So this is breast, colorectal, and lung cancer. We see a response rate that is very similar to prostate. We see an improvement in patients who have metastatic disease that is very similar. And the metastatic in survival in the neoadjuvant setting for breast, colorectal, and lung cancer has been shown, and that's the standard of care. In fact, it's hard to think of a cancer in which neoadjuvant or adjuvant therapy with systemic agents is not the standard of care, except for prostate cancer. So we've spent the past decade exploring this. So the urologists in the room will all say, we've been there before. We saw this didn't work. We're not going to give patients hormone therapy. So this is the 5 of the different studies that were done in the 1990s that examined this. The thing I want to point out is they all had low-stage disease. I mean, for God's sake, this one had T1B disease, T1C disease. The therapy was not that long. It was only about 3 months, okay? And the drugs that we're using, and I'm going to show you data that proves this the case, these were not drugs that were very effective at lowering the testosterone actually in the tumor. And there is data that if you treat patients that need treatment, the more aggressive cancers, you'll actually start to see a benefit. This is a study by Lori Klotz. These are patients that got 3 months of androgen deprivation therapy. Failure was defined as a PSA of greater than 0.2. This is prior to radical prostatectomy versus radical prostatectomy alone. So the patients got the drug, then got surgery, or they just got surgery. And overall, there was no benefit. But if you looked at the patients that had high PSAs, or you looked at the patients that had Gleason 8, 9, and 10 cancer, so those are the patients with aggressive cancer, you actually see hints that there's a benefit, okay? It's not substantial, it's not huge, it's not all the patients are being cured, but you definitely see a difference in terms of biochemical recurrence between these two groups. What about the intensity, the length of time that patients were given the hormone therapy? So Marty Gleave did a rather nice study where they were randomized to 3 months of hormone therapy prior to surgery versus 8 months prior to surgery. Okay? And the margin positive rate was better in the patients that got longer treatment. Okay? No improvement in biochemical free survival, but the intensity of the therapy, by that I mean the duration, clearly had an effect on the biology. And so 3 months is probably just not enough. So I'm going to describe 4 different trials that we've done, not all done at our institution. I mean, our institution was involved in all of them, but these are not all our patients. Could not have done this without our partners that not only helped us enroll patients, but were very important in terms of intellectually thinking about the best way to manage these patients. This was a true partnership. All these studies basically run on the same paradigm. We take patients that have bad prostate cancer on the basis of high volume disease, a lot of biopsies that were positive, higher Gleason score, so not only 7, but 4 plus 3, meaning most of it was 4 with just a little bit of 3. T3 disease, and then we went ahead and did some correlative science, treated them with either intense androgen deprivation versus less intense androgen deprivation, did a radical prostatectomy, and we had 2 primary objectives. The one was to assess the tissue androgen levels. Were we driving down the testosterone and the androgens in the cancer cell? Because, believe it or not, the cancer cell doesn't just depend on the testosterone floating around in a patient's blood. The cancer actually makes its own testosterone. And that's why abiraterone has been useful, because you need to drive down the actual androgens in the cancer cell itself. And then we also assess the response rate, the partial response and complete response rate. Did we get rid of most or all of the cancer? So this was the first study, high-risk disease. Patients either got, LHRH with bicalutamide, with dutasteride and bicalutamide, or a combination that included ketoconazole. Remember, this was done about 10 years ago. These were patients. The most important thing I want to point out here is these were not as high-risk patients as the later studies we're going to look at. There were some patients that had high-risk characteristics, but basically it was anybody who came in. And the key thing is that the tissue androgen endpoint was better in the patients who were treated with more therapy. The patients who received not only LHRH agonists, but also dutasteride, also ketoconazole, and also bicalutamide. And in the maximal blockade arm, 8% of the patients had a complete response compared to 0% in the less intense arm. So right here you can see this is the level of DHT in the patients who received it was zoledronic acid, that's the Z, but LHRH with bicalutamide. And you can see there is still testosterone actually, or dihydrotestosterone in the cancer cell. We have not succeeded in completely blocking the fuel that fires up the cancer cell. Whereas in the more intense therapy, you saw that the testosterone was much lower. So this is a biological rationale why more intense therapy actually should improve patients' outcomes. So this was the second study. These patients received androgen deprivation alone for 3 months versus androgen deprivation plus abiraterone. That's that very strong drug that blocks the production of testosterone. They were biopsied, and then all of them got androgen deprivation and bicalutamide. So essentially, one group got androgen deprivation plus a little bit of abiraterone, whereas the others got a more intense treatment. And then they all underwent a radical prostatectomy. So again, now we're starting to see more patients having high-risk disease. Yes, there are some Gleason 7 cancers, it's about a third of the patients, but the majority, roughly two-thirds of them, had Gleason 8, 9, or 10. Okay? And if you used where they were high risk versus intermediate risk, roughly 75% of the patients will be classified as having high-risk disease. Again, same story. Intraprostatic antigen went down, and the pathologic complete response rate was now 10%, and 14% if you looked at that composite of minimal disease versus no disease. And it was 4% in the combined arm. So here you have the patients who were treated with LHRH alone. Remember, they underwent that biopsy at 3 months, and you can see there's still testosterone around. But in the more aggressively treated arms, the testosterone in the tumor is essentially zero. Okay, this is the next one. We took dutasteride and enzalutamide and tried to compare it to enzalutamide alone. The reason why we did this is because patients basically don't want to take LHRH. And we weren't sure whether the enzalutamide, whether the peripheral blockade, the cancer blockade actually in the cancer cell, was more or less important than the use of systemically driving down testosterone. The idea is there'd be fewer side effects. We're still treating for quite a while, though, 6 months. And the same endpoints we're interested in. So now when you look at it, you can see the majority of the patients have high-risk disease. High risk is roughly 70, 75, 80% of the patients in the two different arms. And again, you can see the androgen endpoint. We've driven down the androgens to an undetectable level. And now our complete response rate in the more aggressively treated arm. Remember, we were hoping that enzalutamide alone would do just as good a job, because patients would much rather just be on enzalutamide. This is a drug that also blocks the effect of testosterone, actually in the cancer cell. But we saw our composite of complete response rate versus minimal residual disease was 0. Whereas 17% in the combination arm had minimal residual disease or no disease. So this is all three of the trials I just outlined. This is the one using various conventional hormone ablation. This is the one that used abiraterone, and this is the one using enzalutamide. And what you can see when you look at the complete response rate and minimal residual disease, as we increase the intensity of the androgen deprivation across the TAPS protocol, we're more likely to receive that complete response. And if we do that in the neoadjuvant arm, we see, neoadjuvant ABI, we see a better response in the combination, and the same with the neoenza arm. And the intensity of this is the most intense treatment out of all of these studies, and you can see we've increased it now to around 17% of the patients having minimal residual disease or no disease in the tumor. And remember, these are patients with high volume prostate cancer. This isn't the patient with a fleck of Gleason 6. These are patients with Gleason 8, 9, and yes, 10 prostate cancer, in which in a lot of the cases all the cores showed prostate cancer. Didn't really seem to affect so much the likelihood of having a disease outside the prostate. Didn't really seem to affect the likelihood of positive lymph nodes. Interestingly, there are those out there that do studies like this, and then they tell the patient, I'm going to be able to do nerve sparing on you because we shrank the tumor. My belief is that's not going to work. The tumor doesn't shrink back into the prostate. It shrinks in the site that it is. And I bet a lot of these patients have residual disease that they just can't detect, and is probably going to recur outside of the prostate. So my surgical plan follows what the original disease was, not what the final disease is. And positive margin rate did go down. This is the latest trial that we have. I'm going to go through this kind of quickly because I only have 6 minutes left. But this is a study where we have more intense androgen deprivation. And I think the key thing is that now our complete response rate, this is the more intense treatment, is now 12%. The minimal residual disease is 18%. So we've gotten up to a 30% of these patients having minimal residual disease or a complete response. Whereas only 16% in the Enza and leuprolide arm. So is this a reasonable endpoint? You know, in other disease states, they actually have used this as an endpoint to get FDA approval for drugs. In bladder cancer, we're all familiar with, but esophageal cancer, rectal cancer, and breast cancer. And the FDA has actually recommended exploration into the complete response rate as an endpoint to accelerate the development of drugs. But again, I keep on talking about how biochemical recurrence, I keep on talking about how we need harder endpoints. So we went ahead and decided we were going to look at biochemical recurrence. We pooled the analysis, about 72 patients, so we could identify from these trials where we could actually see what the biochemical recurrence was in these patients that we treated. Again, I just want to point out these are patients with high-risk disease. Roughly a third had Gleason 7, but the majority had 8, 9, and yes, 10. 75% roughly had high-risk disease. And this is the time to biochemical recurrence. You can see that it's roughly at about 5 years, it's roughly about 50%. We've had 23 patients that have had a biochemical recurrence at 3 years. At the 3-year biochemical recurrence rate there is 70%, and 90% of the patients have a normal testosterone. Time to metastasis is even less, about 7% develop metastatic disease. It gives us a 3-year metastasis-free survival of 95%, and the overall survival rate was 98%. If we compared this to, we plug these patients into the nomogram that they have at Memorial Sloan Kettering, and we see that they actually seem to be, the analysis of the cohort would say about 30% of the patients would have failed, and we would still be biochemically free, and we found it was about 50%. So the majority, it appears, compared to what would be a historical cohort, that there is a benefit. I think the most interesting fact is if you look at the patients that had a pathologic response, those are the patients that appeared to benefit the most. So this is the time to biochemical recurrence on the basis of pathologic downstaging. The patients who were downstage did not recur, compared to the patients who didn't downstage, where the recurrence rate was still better than I would have expected, but there were some recurrences there. And if you had a complete response or a minimal residual disease, none of these patients have recurred that we can identify. Whereas patients that have some residual disease, some of them recur, some of them don't. And I think this is in keeping with the idea that if we are able to kill the cancer cell in the prostate, any metastatic disease should probably be responding to the same agent. I think this is a reasonable hypothesis. This is consistent with it. So we need these neoadjuvant trials, we need longer androgen deprivation correlates with better pathologic response. I think I showed you that. More intense androgen deprivation correlates with better pathologic response. Lower tumor androgens correlates with better pathologic response. I don't think I showed you that, but that's definitely true. And better pathologic response correlates with a lower recurrence rate. So what about this 62-year-old gentleman? His PSA was, as I said, 8.3, had a Gleason 9 cancer. He was placed on one of our trials. He got Enza, dutasteride, and LHRH, and he had a complete response. And 3 years later, he's still NED. So where do I think we're going? So I think we're going to have to treat the primary tumor, whether that's with radiation or surgery. I obviously am a little biased towards surgery, but I think our radiation colleagues cure an awful lot of patients with prostate cancer. Some of the patients are going to be cured. Some of the patients are going to have occult localized disease. Some are going to have occult systemic disease, and some are going to have both. And we're going to need to figure out how to treat the localized disease that's residual, as well as the residual systemic disease. So in conclusion, local therapy is effective, surgery and radiation. I know I spent most of my time talking about surgery, but radiation is an effective treatment for patients that have prostate cancer, and there are many patients who deserve to get it instead of surgery. Radiation and androgen deprivation should be given, and I think with brachytherapy increasingly. These are for high-risk patients. Surgery accurately stages patients, and I think this improves outcomes. Accurately staged patients benefit from multimodality therapy. I hope I showed that to you. They can get surgery, they can get radiation, they get systemic therapy. I think one of the downsides to surgery, to radiation, is basically surgery is then off the table, so they don't have that advantage of getting additional therapy. And I think systemic therapy is possibly the future standard in the care of prostate cancer. We're organizing a randomized trial to look at this, a phase 3 trial, appealing to the patients in the room. One of the reasons why our breast therapy colleagues are so far ahead of us is not only that patients don't speak up about the disease, but male patients don't really enroll in randomized clinical trials as much as our partners. And I think that impacts on our ability to give people hard data as we move forward. I think that's the way forward, is to have good randomized trials that actually demonstrate an advantage to a particular treatment. So obviously I didn't do 95% of this work. Whenever I said I really meant we. Whenever I said we, I really mean them. So these are the people who actually did the vast majority of the work. Thank you very much.